Hello, everybody, and welcome to the PT on Ice Daily Show. My name is Christina Previtt. You guys saw me on Monday talking about pregnancy and postpartum, but I am also the lead faculty for one of the lead faculty with Dustin Jones in Modern Management of the Older Adult. So we have 2 online courses and 1 live course for working with all things Jerry PT. And we are super excited that we are actually going to be beginning live courses, crossing my fingers, in August and in the fall. So the first course that I'm teaching, hi guys, the first course that I'm teaching is in Alaska in September. And then I'm actually going to be teaching a course at my clinic in Kingston on September 26th. So hopefully those are all good to go with everything that's unrolling with COVID-19. And if you guys are not really wanting to go to live courses and you want to check out our online, we just started our summer cohort of Modern Management of the Older Adult Essential Foundations. But our next cohort of Essential Foundations and Advanced Concepts starts in September. And just to note that you do have to have taken the online version of Essential Foundations to take the online version of Advanced Concepts because of some of the assignments that we do in that course and some of the content. All right, so we are getting ready for the virtual sampler. We were supposed to be running the sampler in Washington, and I was so sad that we weren't able to head down to Seattle in order to have all the faculty come together. But what that's meant is that we have been able to open it up and allow all of our faculty to do virtual presentations. So I'm going to be doing 2 actually. So I'm doing with the pregnancy and postpartum faculty, we're doing peeing on the platform. But for the older adult faculty, we are actually linking with fitness athlete and really talking about overhead capacity and talking about from Matt Fraser to Doris, what does overhead capacity look like and how do we as PTs make sure that we are working to strengthen the shoulder joint in the means necessary for a high level athlete like Matt Fraser, a CrossFit athlete, but also to our older adults who may be at the threshold of being able to be independent at home and community dwelling versus needing to transition to long-term care. And oftentimes as a PT, I think we really focus a lot on the lower extremity because it's so important for things like transfers and community ambulation. And oftentimes the reason why people come to see us for anything related to the upper extremity is more around pain. And so the first thing that we need to be aware of is what is the natural history of the shoulder joint? What I mean by that is what are normal changes that happen with age that may not be necessarily a nociceptive source of pain or maybe something that we won't be able to change. And what we know is that we do lose range of motion in the shoulder joints. So some of our scapulothoracic kinematics as well as our range of motion in general tend to decline in the glenohumeral joint as we get older. And what that can mean is that we're no longer able to achieve 180 degrees of flexion and abduction. And especially if there's a reduction in joint space in the glenohumeral joint, indicative of some sort of osteoarthritis, we're gonna have that reduction in those rotation components, especially external rotation, based on the way that the joint is gliding within the joint capsule and where that loss of joint space tends to happen primarily. What can happen? Usually what I say with something along the aging joint is oftentimes it's a use it or lose it type of principle. In a CrossFit athlete, we are using our max shoulder range of motion all the time. When we are kipping, we are going into that thoracic extension, full shoulder range of motion, and closing down that joint. And so we are strengthening in that 140 to 180 range in flexion. If you're not in the CrossFit space or your sport doesn't involve a ton of overhead work, think about how often you really are using that max shoulder range of motion. As a weightlifter, it's super important for me. I need to have 180. But for my clients who are in their 80s, oftentimes they are never going to that range of motion. And what ends up happening is over decades of time, we are seeing that there is a decline in shoulder range of motion. This is going to be coupled by the increase in thoracic kyphosis. We have an increase in thoracic kyphosis of about 3 degrees per decade, which is going to impair the ability to hit those upper ranges between 160 and 180 degrees of flexion and abduction. So the first thing that you're going to do when you're looking at the aging shoulder is assess active versus passive range of motion. Can they actually get a lot higher than they are actively able to do? Because what I see with a lot of my clients who are seeing me for pain or who are having trouble with ADLs and IADLs is passively I can usually get them there. It's actively that I can't. And it's harder when you've had years and years of deconditioning to actually get back to those higher ranges of motion, and it's going to take quite some time. And what that has made me do is reflect on what my goal may be for a community or homebound older adult in regards to shoulder range of motion versus if I was seeing an athlete, what are my expectations for recovery with them? And I've talked to some surgeons who have done things like rotator cuff repairs and shoulder arthroplasties, total or reverse total shoulders. And oftentimes they're trying to get them to a 90 to 110. And I thought that wasn't really a ton of range of motion. And I wondered if they would actually be able to complete a lot of their ADLs and IADLs with that range of motion. So of course, I went to the literature, and it is very cool. They did a systematic review that looked at the range of motion requirements, specifically talking about flexion and extension. I have to look a little bit further into that external rotation and rotation component that's really important for things like putting on a jacket or putting on a seatbelt. But this gave me a lot of information based on a pooling of studies around what are the actual range of motion requirements for somebody who is older. And so what it showed was the most range of motion that's required is for bathing and for putting something away in regards to flexion into a cupboard. So the range of motion requirement is usually about 40 degrees into putting something into a cupboard and for washing our hair. So I was reading this study. It was funny because my husband must have thought I was insane because I was trying to, I was like thinking about, they were like scratching your head, how much range of motion would you need? And I was like, well, I haven't really thought about that because I don't have a shoulder injury that's preventing me from doing that. And you need about 130 to 140 degrees of range of motion to do things like put your hair up, right? You're going to see me from the side. To scratch your head, to wash your hair. And so for my older adult clients who are looking to be bathing independently and do not want to give those things up, those are going to be really important goals that are going to be reflected in my treatment plan. The other thing is around toileting. So that's where you're thinking more in the extension quadrant, is that in order to wipe your bum, you have to have about 30 to 40 degrees of shoulder extension. So in order for you to be able to independently toilet, you have to have that range of motion requirement in order for you to be able to do that. The other thing where we probably don't think about extension is for our older clients who are having trouble using their lower extremity solely for transfers. So if they are trying to get up from a chair, a lazy boy, a couch, they have to have a certain amount of extension in order for them to be able to push up. And oftentimes that extension quadrant, which we don't lose that range of motion as quickly as flexion, is sometimes maybe forgotten about, or we don't really think about it as much as the flexion quadrant because a lot of our goals tend to be focused on that flexion and abduction quadrant. And so for many older adults, as they get older, we see this decline in range of motion. We're probably going to see that their new normal is probably around 130 to 140 degrees of flexion and abduction and 45 degrees of shoulder extension. What happens to the integrity of the shoulder joint? So those are the expectations that we're going to have in regards to treatment. what's the literature saying in regards to the expectation around pathology if we were to MRI an individual? I'm sure you guys have seen that the rotator cuff musculature has gone along the same lines as some of the low back pain literature and the arthritis literature around the fact that one of the biggest risk factors for a rotator cuff issue is age. So we know that 65% of asymptomatic individuals over the age of 65 have a full thickness rotator cuff tear. That increases to about 50% if you're over the age of 80. If you have a painful shoulder on the left side and you're over the age of 65, you have a 50% chance that you also have a tear that you don't know about that is not causing you pain on the contralateral limb or on the right limb. All of this literature has been coming out around what that looks like. And sometimes that can be that we can dismiss some of these images, which I don't think we mean to, but we kind of have this like you are not your image type of mentality. And especially as we learn more about pain neuroscience education around Justin Dunaway's course with persistent pain, we learn a lot more that we can't necessarily have a good localization of pain based on what is on the image. What we do know is that for these individuals over the age of 65 who do have an asymptomatic full thickness tear, it can take, in 2 to 5 years, those individuals, I think it's 30 to 40% of those individuals develop pain in the shoulder with the tear on 2 to 5 year follow-up. So this was a prognostic study that followed people over time in over 65, MRI'd both shoulders and looked at, the percentage of individuals that had asymptomatic tears and then the percentage of them that developed pain further in the future. And that study was actually pretty surprising to me because it meant that we can't necessarily dismiss some of those pathologies, but it's really important to note that some of our rotator cuff musculature isn't necessarily going to be fully maintained as we get older, even if we don't have shoulder pain. And so what is the reason for that? Why are we seeing that older adults are having less integrity or these partial and full thickness tears in their rotator cuff musculature? The thought is around the integrity of the musculotendinous junction in the rotator cuff and the vascular supply. So what we know is that there's a rotator cuff thinning that occurs with age based on the integrity on the musculotendinous junction in the rotator cuff. And that's something that happens very naturally with age. What ends up happening is there's more fatty infiltration, which affects the ability of the muscle to contract, and we have a loss of hypertrophy, so a decline in the thickness of the muscles in that area. That in combination with a poor vascular supply to the anterior aspect of the rotator cuff leads to this essentially like kind of perfect storm in regards to the development of any sort of rotator cuff issue. And that in combination with things like prognostic factors around like if you've smoked or if you have metabolic disease, which is going to create those atherosclerotic plaques, which is going to decline the vascular supply even more, as even in the periphery. We think about it in regards to heart disease and heart attack and stroke. Then we're going to be thinking about the fact that we're going to have to have that lack of blood supply, and it's going to make vulnerability. So just things that we would need to be thinking about in regards to our goal. So I have a question on Instagram that says, what is your favorite Therex to improve scapular upward rotation with end range shoulder flexion? So that's a really good question. So it depends for me if I have a client, how symptomatic they are. I tend to like doing things like I've seen the wall angels, but for a lot of my going in the Jerry PT space, they are can sometimes have a tough time with that. So oftentimes what I'll do is I'll get them on the plinth first and do more of a closed kinetic chain flexion by having them coming here towards the plinth and slowly coming back in order to try and facilitate upward rotation if some of their scapular kinematics are there. I'll almost do like a mobilization with movement there. And then at home, I'll try and get them to work on, having some sort of rolling pin or something here so that I can get a little bit of free movement and allow their shoulder blade to come up. And hopefully with the combination of some of the manual therapy, that mobilization with movement and solidifying that with some of the Therex, I can get a little bit more of that movement. The other caveat to that is it depends if the reason why they're not having that upward rotation is because of a fixed mechanical thoracic kyphosis, which is affecting their kinematics. And so it really kind of sometimes depends how much realistically I think they're going to be able to get in regards to that scapulothoracic rhythm based on the client. So I hope that answered your question, Kirk. Okay, so kind of bringing this back to the aging shoulder, the thing that we need to be thinking about in the Geri PT space is what our expectations are. So we know that we need about 140 degrees of shoulder flexion and 45 degrees of shoulder extension in regards to ADLs and IADL function. We need to be strengthening up the shoulder. There is a use it or lose it principle, and oftentimes, especially if you're not a CrossFit athlete who is using those upward ranges, we just lose strength. So comparing active to passive range of motion is going to give us a lot of indications around what to expect and where the strength deficit may lie. And we might not actually have to do any passive range of motion, and all of our focus has to be on strengthening up that shoulder. The third thing is around the expectation in regards to images. We know that 50% of individuals over the age of 80 have a rotator cuff repair who are asymptomatic on MRI. What we also know is that people with full thickness tears who are asymptomatic are in some cases more likely to develop pain in the 2 to 5 year follow-up period. And we don't know why that happens, what that is, what that causes, what some of the risk factors are. We still don't know that. And then fourth is that it's when we're thinking about the Therex component, we have to be breaking down the needs of our client, but it's also a variety of degree, not kind. Even the upward rotation and that shoulder flexion work, oftentimes for our CrossFit athletes, we would be doing it with a foam roller against the floor or against the wall, where we would be doing things like wall angels to allow that scapula to come across the thorax, but also allow for that flexion. I can take that and modify it down to a lower level, and I'm still getting the same stimulus, but I'm doing it in a different way that would help my client who doesn't have the same baseline level of flexibility, strength, and mobility. All right, I hope you guys found that helpful. You guys are going to be seeing me a lot more on the podcast, which is super exciting. If you guys have any other questions, let me know. This is also going to be a big topic around the sampler. Dustin and I are going to be powwowing for 2 hours around overhead capacity in the older adult. The fitness athlete crew is going to be doing the same thing, and we are going to be creating this full spectrum of care depending on the client and helping with the shoulder in general for one of our main themes for this year's sampler. So have a great Wednesday, everyone, and we will see you on the podcast soon. You're so welcome in it.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.